Next is osteochondroma. Now this is again a very important tumor to have a discussion on. Like characteristically, one of the characteristic finding for this finding, it was considered to be a developmental abnormality, all right, is that the growth of the tumor, it ceases or it stops once the skeletal maturity is attained. That the growth of the tumor, it stops when the skeletal maturity is attained. All right, that is one characteristic finding for osteochondroma. Next is, what is Trevor disease? Now, the Trevor disease is that if the osteochondroma is originating from the epiphysis. So, epiphyseal osteochondroma, because osteochondroma is originating from, or it is a metaphyseal tumor, but in some of the rare incidences where the osteochondroma is taking origin from the epiphysis, then it would be called as Trevor disease. Next, one of the very important hallmark of osteochondroma is that the cortex of the tumor, it is in continuity with the cortex of the bone, parent bone. Just try to understand the meaning of this statement. For example, if this is a parent bone and this is a tumor, so the cortex of the tumor or the medullary canal of the tumor is in continuity with the parent bone. It is not like this is the cortex of the tumor and the parent and this parent bone and the tumor are having two different cortices. No, it is in continuation. All right. So this is the hallmark. This is the importance characteristic finding, that the cortex of the tumor is shared with the cortex of the parent bone tumor. With intact cortex is never osteochondroma. If the patient is having an intact cortex, all right, the tumor with the intact cortex is never considered to be an osteochondromatous lesion. It is something else. Next is diaphyseal achenesis. Now, what is diaphyseal achenesis? It is multiple osteochondromatous lesion. If a single patient is having or demonstrating multiple osteochondromatous lesion or multiple exhaustosis, because the other name which is given to osteochondroma is exhaustosis. So, if the patient is having multiple exhaustosis, so it will be called as diaphyseal achenesis. Next, what are the possible or potential complications related to this tumor? Now, just try to understand. If this is a bone and here we are having from the metaphysis the tumor which is emerging. Now, one of the potential complication is the formation of the bursa over it, and this bursa might get inflamed. So, bursitis is considered to be the most common complication which is related to this osteochondromatous lesion. Second is neural compression, means it can lead to a vascular as well as neural compression. It is very easily explained or understood. Third is, there is always a possibility for this outpouching of the bone to get fractured without any fracture in the parent bone. So, fracture is also a possibility. Then finally, the fourth one is osteonecrosis of the cartilaginous cap, because if the cartilaginous cap, as I told you when we were talking about the X-ray finding, that the cartilaginous cap is a feature of osteochondroma, and if this cartilaginous cap gets necrosed, the condition will be exceedingly painful. So this is again, and it can lead to a lesion which is non-healing kind of a lesion. So osteonecrosis of the cartilaginous cap, and finally the malignant transformation. Even the osteochondromatous lesion can be converted into a malignancy. So malignant transformation. Now, the malignant transformation will happen obviously into a chondrosarcoma, but what are the features which are suggestive of malignant transformation? The first feature, the most important feature which is suggestive of malignant transformation is increased size of cartilaginous cap. The cap which is present onto the bony tumor, if there is a progressively increasing size of this cartilaginous cap, it is a feature which is consistent with the malignant transformation. Second is increasing size of bone tumor beyond skeletal maturity. Now, all of us know about one of the characteristic finding for osteochondroma is that the growth of the tumor, it stops at skeletal maturity. But if it continues to grow beyond skeletal maturity, then it is a sign that it could be getting converted into a malignant transformation or chondrosarcoma. Then the third one is increasing the calcification of tumor. So, if there is a persistent increase in the calcification of the tumor, so these are the three signs which you have to remember, which are suggestive of malignant transformation of this particular condition. So, hope everything is clear related to this particular topic, that is osteochondroma. Remember, osteochondroma is one such condition which the examiner are asking today, and it is getting more and more asked on the basis of its appearance. As far as X-ray for this condition is concerned, it is a spot diagnostic X-ray. Although in the end, after the completion of all the tumor, we are going to have a discussion on the X-ray, but it is something which you can never miss. Like there will be a bony outgrowth from the metaphyseal lesion, which obviously is covered by the cartilaginous cap, which you cannot see on the X-rays. All right. So this much you need to remember about osteochondromatous lesion. With the continuation of the benign tumors, or with the continuation of the tumor in the metaphyseal location, we have talked about osteosarcoma, chondrosarcoma, osteochondroma. Now is the time to discuss about the cystic lesions of the bone, and it is simple bone cyst and aneurysmal bone cyst. You know, simple bone cyst is also known by the name of unicameral bone cyst. Aneurysmal simply is aneurysmal. Now, what is the thin line of difference in between the two? That simple bone cyst usually is a clear, unsegmented kind of a cyst. Just imagine if this is a bone, all right, and there is a presence of a cyst, then this cyst is usually a clearer cyst without having any fragmentations or septations. On the other hand, in case of aneurysmal bone cyst, the cyst is multiseptated, it is fragmented, it is divided into further compartments. So that is a septated or multiloculated metaphyseal cyst. So that is the first difference in between the two. Difference number two. Now, simple bone cyst is gradually expanding kind of the cyst, while aneurysmal bone cyst is relatively rapidly expansile kind of a cyst. As far as cortical thinning is concerned, you just try to understand that if the cyst is gradually expanding, then the cortical thinning will be relatively a late feature. While in case of a rapidly expansile kind of a tumor, it will lead to a adjacent cortical thinning of the tumor, and that is the reason why the aneurysmal bone cysts usually are eccentric kind of the cyst, all right, while simple bone cysts are usually the centric kind of the cyst, because they remain within the confines of the bone for a long duration of time, but aneurysmal bone cysts are eccentric. All right. Next, as far as the fluid which is aspirated out of the simple bone cyst is concerned, it is simple straw colored fluid. Simple. It is a straw colored fluid. While in case of aneurysmal bone cyst, it is a brown fluid because it contains the degenerated products of the blood degeneration. It contains the degenerated products of the blood. That is the reason of this color, that is brown color in the aspirated aneurysmal blood, cyst fluid. One thing is that they used to ask this question, that what is Brown's tumor? Brown tumor. You know, brown tumor, although aneurysmal bone cyst is a tumor and it consists of brown fluid also, but brown tumor is not aneurysmal bone cyst. It is hyperparathyroidism. So don't get confused with this kind of a condition where they can ask you, or they have asked it multiple of the times in the form of a one-liner, that which of the following is a brown tumor. Aneurysmal bone cyst is always kept in the options, but it is not a term which is coined for aneurysmal. It was the term coined for hyperparathyroidism. Next is, you know, simple bone cyst. It could be asymptomatic or symptomatic, but aneurysmal bone cyst majority of the time, because of its eccentric pattern of the growth, it is symptomatic. So most of the time it is symptomatic. As far as management of this concerned, simple bone cyst, simple excision of the tumor is required. Aneurysmal bone cyst, extended curettage is required. So this is how you are going to differentiate in between the two, and this is how you will identify the two tumors when we are going to have a discussion on the X-rays itself. Next in the line of the tumor is enchondroma. Now, enchondroma in itself is important because of three reasons. Reason number one, it is the most common overall tumor of bones in hand. That is the part number one. Part number two is, it is a component of Ollier disease. Now, what is Ollier disease? It is multiple enchondromatosis. Ollier disease is multiple enchondromatosis. And the possibility of malignant transformation, you know, with this Ollier disease is as high as, you know, the incidence of malignant transformation in Ollier disease is as high as 20%. So this is the reason why it is important. Multiple enchondromatous lesion or multiple enchondromatosis. Next, another syndrome with which it is this enchondroma is associated is the Maffucci syndrome. Maffucci syndrome is actually a triad of 3 features. The first one is multiple enchondroma. Second is cutaneous hemangioma. And the third one is phlebolith. So Maffucci syndrome is important because of its components. Multiple enchondroma associated with cutaneous hemangioma is a Maffucci syndrome. And the possibility of a malignant transformation for this triad, or possibility of a malignant transformation associated with Maffucci syndrome, is as high as 40%. So they have asked this question also, that which of the following benign tumor is having the highest probability of getting converted into a malignancy. And in the options provided were multiple enchondroma and cutaneous hemangioma, the giant cell tumor and osteochondroma. So obviously the answer for that question is 40% possibility of malignancy associated with multiple enchondroma and cutaneous hemangioma. That means Maffucci syndrome. So these are the 3 reasons why this tumor enchondroma is particularly important for you to have a discussion on. Next is Ewing sarcoma. Now, as far as Ewing sarcoma related questions are concerned, they used to ask the question out of 2 contexts, or the 2 patterns in which the questions are asked. Pattern number 1, all of the following are true related to Ewing sarcoma except, and second is asked based on its X-ray appearances. Now, already we have talked about the X-ray appearance is the onion peel appearance with the diaphyseal involvement. You will mark the answer for Ewing sarcoma straight away. Now, what else is required for you to remember under this heading? Point number 1, that there will be pain as far as clinical features are concerned. There will be pain, tenderness, swelling, limitation of movement associated with fever. And all these clinical features are similarly seen in case of acute osteomyelitic patient. In case of acute osteomyelitis, when we were having a discussion of that particular condition, I told you that the abscess that which you are draining out, half of the abscess has to be sent for histopathological analysis because of the very common clinical features shared by these 2 conditions. That is acute osteomyelitis and Ewing sarcoma. So it closely mimics acute osteomyelitis. It is one of the most common differential diagnosis for Ewing sarcoma, that is acute osteomyelitis. So whatever the aspirate which you are draining out, it has to be divided into 2. One has to be sent to a microbiological department for culture sensitivity and the other one for the histopathological evaluation. Second, the most specific immunohistochemical marker for Ewing sarcoma is MIC2 or CD99. This is something which you have to remember. The most common cytogenetic translocation responsible for this abnormality is T1122 to Q24Q12. That is the most common cytogenetic translocation which you have to remember. Ewing sarcoma cells are PAS, that means periodic acid shift positive. They stain positive to periodic acid shift because of the presence of glycogen. They contains glycogen. Ewing sarcoma cells, it contains glycogen. Alright, that is the reason why they are PAS positive. Next, as far as poor prognostic factors are concerned, metastatic lesions are poor prognostic indicators. Presence of fever, anemia are considered to be a poor prognostic features, and lactate dehydrogenase presence along with the raised ESR. So they are considered to be a poor prognostic indicator for Ewing sarcomatous lesion. As far as one of the feature related to Ewing sarcoma is concerned is that they are Ewing sarcoma cells, they are highly radio sensitive. Ewing sarcoma cells, they are highly radio sensitive. It is being written that Ewing sarcoma cells, it melt on radiotherapy. When they are subjected to radiotherapy, it melt on. So it should be managed by radiotherapy? No. Primary radiotherapy should be avoided in the management of Ewing sarcoma because of the possibility of recurrence. And that recurrent Ewing sarcoma tumors are radio resistant. Hopefully you have understood. So despite the fact that Ewing sarcoma cells are highly radiosensitive, primary radiotherapy should be avoided because of the recurrence, and that recurrent Ewing sarcoma are radio resistant. They are going to have a poorer prognosis. Although all Ewing sarcomatous cells are high grade tumor cells and they will be sharing a poor prognosis overall.